It is said there cannot be universal health coverage without enhanced sexual reproductive health and rights. This is why the Zambia Association of Gynecologists and Obstetricians, ZAGO, brings you Inside Health TV program, a program that promotes sexual reproductive health rights and also discusses various health issues affecting people from all walks of life. Join me, Tumenji Chinjili, every Sunday from 20 to 21 hours on KBN TV, DSTV channel 279 and Topstar 102. We'll also be live on Zago and KBN Facebook pages and YouTube channels. Tune in and share that health experience. Hello, good evening and welcome to our 6th episode of the Inside Health TV series program right here at KBN Television. This is a program that is brought to you every Sunday from 20 to 21 hours by the Zambia Association of Gynecologists and Obstetricians, ZAGO, with the support from the International Federation of Gynecology and Obstetrics, FIGO. I'm your host, Tumenji Chinjili. Remember, you can be part and parcel of this program by following us on our Facebook pages, which is ZAGO, as well as KBN TV, and not forgetting, for those who love YouTube, that you can also subscribe to our YouTube channels, which is Zago and KBN TV. So for the past weeks, we've been looking at different issues that are affecting us as Zambians, and also beyond. These are health issues that are affecting us. We've discussed various of them. And this evening, we'll be looking at another problem that humanity is facing at the moment. This evening, we'll be looking at cancer. Cancer is a group of disease involving abnormal cell growth with the potential to invade or spread to other parts of the body. There are over 100 types of cancers affecting humanity. This evening, we are just not discussing cancer in general, but we'll be discussing specific type of cancer, which is cervical cancer. Cervical cancer, just like any other cancers, are among the deadliest diseases confronting our people today. And it is for this reason that the public needs to know what causes it, how it can be treated, and how people can navigate from contracting it. I mean, how can we possibly prevent ourselves from getting this disease? However, I'm not alone in the studio. I've been joined by Dr. Aubrey Shanzi, who will help us understand more about cervical cancer and also to explore more about this topic. Doc, good evening and welcome to the program.
Good evening. Thank you so much, and thanks to the viewers.
Thank you, Doc. So, Doc, we'll get right straight into the program. I believe this is not your first time to be part of this program. So, to begin with, Doc, what is cervical cancer?
Cervical cancer is a genital tract cancer. It's a cancer that women have, a very common cancer. You know, when you talk about the uterus has parts. It has the body and so on, and it has what we call a mouth. And in medical terms, it's the cervix. So that cervix, the entrance to the uterus, sometimes develops this cancer, what you described already as abnormal growth of cells. So cells of the cervix start growing abnormally and uncontrollably, and they start invading other tissues and so on. So when these cells start doing that in the cervix, that's what is called cervical cancer. So it's simply the cancer of the genital tract, specifically attacking the part of the uterus that we call the cervix. That is what we call cervical cancer.
Okay, great. So what really causes this type of cancer?
Yeah, so cervical cancer is a very special kind of cancer, because the beginning of cervical cancer is somebody contracting the human papilloma virus. So a woman has sexual intercourse with a man, for instance, and they get this human papilloma virus. So there are different types of human papilloma virus, but as we've learned a lot of virology when we've had the issues of COVID. You know, there are serotypes of COVID, this type and this type, Omicron and so on. Even with human papilloma virus, there are so many types of human papillomavirus. So there are a few that end up liking or have a predilection to residing in the genital tract. So when a woman contracts this virus, it goes and resides in the cells of the cervix. And when it resides in the cells of the cervix, it kind of changes the DNA of the cervix and of the cervical cells. And these cells starts, like you described at the beginning, start dividing abnormally because they've been attacked by this virus. So this abnormal multiplication is what eventually results in cancer. So to put it in plain terms, really, cervical cancer is kind of like a sexually transmitted cancer. So somebody gets a virus, that virus goes into the cells of the cervix, and then the cells of the cervix become abnormal, and then they start multiplying. So it means that if somebody does not get the human papillomavirus, they cannot get cervical cancer, generally speaking. But there are other things, because everyone who's sexually active actually gets the human papillomavirus at some point in their lives, because the human papillomavirus is quite common in circulation. Okay. So every woman, every man actually gets the human papillomavirus at some point. But what happens is that the body has a way of clearing it. You know, we have immunity. We have this natural immunity in our bodies that clears viruses, clears bacteria. It's not all the time that you have a virus and you have bacteria that you have to go to the hospital, take antibiotics. Your body has power to clear viruses. So what happens in the cases of cervical cancer is that when somebody gets this human papillomavirus, when a woman gets this human papillomavirus, for some reason, the body does not clear this human papillomavirus quickly enough, so much that it gives time to that human papillomavirus to cause that change in the cells of the cervix. So things like smoking, for instance, will make this human papillomavirus stay longer in the cells of the cervix and cause cervical cancer. The other things that might make somebody predisposed to these viruses staying longer in the cells of the cervix are things like HIV or any other causes of your immunity being low. So if your immunity is low, it means that your body won't clear those viruses quickly enough, and therefore that virus remains in the cells of the cervix for a long time, and then they cause that change that we've already described and causes cervical cancer. So the other issue that predisposes to cervical cancer is just multiple sexual partners, of course, because if you have multiple sexual partners, it means that you are going to have repeated infection with the human papillomavirus. Your body clears it, then you have another one. Your body clears it, then you have another one.
So Doc,
just
on that one, just to be clear, in other terms, are you saying men are carriers of the papillomavirus?
Not really men per se. All men and women have the human papillomavirus, because we can't really say men are carriers, because where did the man get it from in the first place? So this is a virus which is in circulation. It's kind of like gonorrhea and syphilis and so on. So we can't say women are the carriers of syphilis or women are the carriers of gonorrhea, because even the woman got it from someone herself. So it's just a virus that is in circulation. A woman can be a carrier that transmits to a man, and the man transmits to another woman, just like every other sexually transmitted infection. So that's how the human papillomavirus is spreading. So we're just talking about the other things that are predisposing somebody to getting cervical cancer. So we've talked about smoking, we've talked about your immunity being low, for instance, being HIV positive, having a low CD4 count, and so on. When you're HIV positive, we've talked about multiple sexual partners, and so on. The other thing is starting to have sex at an early age. So if a woman has a first sexual intercourse below maybe 16 years old, around 16 years old, the cells of the cervix are not mature enough to let's say, to fight the virus when it gets in the cells. So it means that that girl has that human papillomavirus for a long time, because the cervical cells are premature. They easily get the virus, and they easily don't clear it. So it means that she stays with that virus for a long time, and then they end up with cervical cancer. So early sexual debut is really one of those things that also predispose to cervical cancer, because the cells of the cervix are not mature enough to handle the human papillomavirus, or they are not well developed enough, so much that the human papillomavirus easily enters them. So those are the things that really predispose to cervical cancer, together with the human papillomavirus. These things are working together, and so on. So from this description, it also means that from what we've said, is that the human papillomavirus really needs some time. You don't just get a human papillomavirus today and then tomorrow you have cervical cancer. They need time. So the virus needs to stay in the cells of the cervix for a long time, cause those changes, and then a woman ends up with cervical cancer in the end. Yeah.
How can one person know that she's got cervical cancer?
Yeah. So there's it's maybe the question is what happens if somebody gets cervical cancer. So what happens is that the commonest symptom of cervical cancer is bleeding. Yeah, so a woman has abnormal vaginal bleeding. Maybe there's a lot of bleeding. Maybe there's intermenstrual bleeding, meaning that somebody's bleeding in between menses. There can be postcoital bleeding, so bleeding during sexual intercourse. There can be discharge, abnormal vaginal discharge. So those are the symptoms that women who have cervical cancer usually present with. So bleeding of different kinds, intermenstrual, bleeding meaning bleeding in between menses, postcoital bleeding meaning bleeding during or after sex, and they can just be abnormal vaginal discharge. Of course, when the disease is advanced, it has spread to other parts, maybe it has spread to the bladder, somebody can be leaking urine, it has spread to the rectum, somebody can even leak fecal matter. If it has spread to the kidney, somebody can have kidney failure and so on. But I think the important thing for this particular discussion is women understanding the early signs, which are the ones that we've mentioned, that women should not ignore abnormal vaginal bleeding.
So, in the early stages, as you've explained the symptoms already, can one experience pain? Or it's just maybe the bleeding, there's no pain, there's vaginal discharge, then there's no pain. How can one really know?
Yeah, early on there's not really pain. I think the pain really starts when the cancer starts spreading into other tissues. Then there's pain and other things, things like anemia, because you're bleeding all the time. The woman is bleeding all the time, they might be anemic. Those are like complications, but the main thing, the earliest things are abnormal vaginal bleeding. Postcoital bleeding is quite characteristic of cervical cancer, so we need to be aware of that and not ignore abnormal vaginal bleeding. I think every abnormal vaginal bleeding should be evaluated. A woman needs to come to the hospital, she gets checked, and then she gets informed about what the cause is about. Then you can relax, but we shouldn't ignore abnormal vaginal bleeding because it's a big early sign of cervical cancer.
So you just talked about screening. So could you just explain more? How's the procedure? What's done?
Yeah, so like you rightly put it, we don't want women to get to the point where they've come with cervical cancer. Because in our setup, really, once you get cervical cancer, life becomes difficult.
Yes.
We only have one, as you know, we only have one hospital treating cervical cancer in the country, at UTH, and so on. So this country is very big. There are people everywhere. Western
Exactly.
Province, Northwestern, Wapula, and so on. So a woman getting access to these facilities is really hard. So we don't want women getting to that point where they have cervical cancer. So I think this screening question is like, I think is the most important part of the question, because we don't want to get women to that point where they end up with cervical cancer. So locally, there are several methods of cervical cancer screening that are available. So we have what, I'll start with maybe the less common ones. We have what is called HPV DNA testing, where we look for the HPV virus, the one we've talked about, from a sample that we've got from a woman. That's one. I think in Lusaka, maybe only 10% of women get this kind of test. So it's not a common test that most women are using.
Why is it so?
Because I think it's more expensive, and there are very few machines to do that in the country. So we just have a few facilities that can do that at the moment. Hopefully, as time goes, we get more and more facilities. The second method, which was very common in the past, was a pap smear. So what happens is that we put some instruments in the private parts of the woman to have a look at the cervix. So when we look at the cervix, we get a few cells from the cervix, then we put them on a slide. When we put them on a slide, then we look at the slide on the microscope. And then we see if the cells have become abnormal. You remember in our discussion, those abnormalities that the human papilloma virus is causing in the cells of the cervix.
Yes.
So we look at those on the microscope and see those abnormalities. Then we can say, I think these cells are likely going to become cancer in the future if we don't treat you early. So the idea of screening is really that we want to catch the changes in the cells of the cervix before they become cancer. That's the idea of screening. Kind of you finding the eggs of a snake before they hatch.
Yes.
So the eggs of a snake are not snakes. So if you destroy the eggs, then there won't be a snake.
Yes.
If you leave the eggs there, then
They'll be there.
the snakes will come. So when we are doing screening for cervical cancer, it's kind of like looking for cells or eggs for cervical cancer. Things that if they are left alone and not treated might become cervical cancer in the future. So that's the second method. So we are looking for those abnormalities that are telling us that these cells of the cervix look abnormal and they might become cervical cancer in the future. And therefore we treat the abnormalities in the cells before they become cancerous. Then the last common method of cervical cancer screening, which is I think being used by 90% of the population in the country, maybe is what we can talk about a little bit more. So in this method, what happens again is that we put some instruments in the private parts of the woman so that we can have a view of the cervix. So we look at the cervix, then we put some acetic acid on the cervix. That's vinegar, the common vinegar that we use in the kitchen. Yes. Okay. So we put some vinegar on the cervix, and then we observe the changes. So the cells that are abnormal become white. So we can see white areas or patches on the cervix. So those white patches on the cervix symbolize the fact that there might be changes inside those cells that are making them look white. Because if you put vinegar on a normal cervix, it just remains the way it is. Nothing changes.
It doesn't react.
Normal, yeah, and pink. It doesn't react. Now when we put vinegar on an abnormal cervix, we see these white patches on the cervix. So those tell us that there's something in these cells that are making them look white. So we look at those white patches and we just remove them. We can remove them using heat. We can remove them using cord. like temperatures that are very low, you just freeze them and their cells die, because cells can die by heat, they can die by freezing and so on. So the beauty with the screening methods we have, which I've described right now, it's called visual inspection with acetic acid. So we put acetic acid on the cervix and then we have a visual look at it. Sometimes we use a camera to take a picture of the cervix, because if we take a picture of the cervix, you know, cameras are very sophisticated these days. So you can magnify, you take a good picture and then magnify the picture and have a closer look, because our naked eyes might not see everything clearly. But if you use a proper camera, you get a picture, then try and increase and magnify, then you can see more. So that's really the common method we are using to do cervical cancer screening in the country. 90% of women in this country get screening using that method. So it's like I'm repeating, it's called VIA, visual inspection with acetic acid, and then we get a picture of the cervix. So patients shouldn't be, or clients, since they're not patients, people coming to get the screening, they're not patients, they're just coming, they're okay, they have no symptoms, they're not bleeding, so they shouldn't be afraid when they see our cameras, because we're just trying to have a good look at the cervix and have a way to magnify the picture of the cervix, so that we can have a proper look. So those are the methods of cervical cancer screening available. People might be afraid, they see the cameras, they see the instruments we are using to visualize the cervix, but generally the process is relatively comfortable. Most women will complain just that because the instruments we are using to visualize the cervix are kind of metallic, so they can be cold. It's like somebody has put a metal on your body, it feels cold, yeah, and so on. So that's the main complaint. As long as the woman is relaxed, the healthcare workers have explained clearly what's going to be done, the discomforts that they're going to have, the other issues, and usually it's a relatively straightforward procedure. Maybe I can add that, you know, all women, the people who are supposed to come and screen, since we've talked about screening. So if a woman is HIV positive, everyone who's between 15 and 60 years old should come and screen. For HIV negative women, we want everyone who's 25, between 25 and 60 to screen. So the difference is that if somebody is HIV positive, the screening starts earlier.
Okay.
15 years old, for the reasons we explained at the beginning. Because if you're HIV positive, the immunity is not
Low.
The immunity is low, and therefore that human papilloma virus stays in the cervix, might stay in the cervix longer. You have a higher risk, so it's better we start the screening early. And this is done yearly, every 3 years, I mean, the cervical cancer screening. So if you get screened today, you're okay, then the next time you get to be screened is 3 years later, unless we found an abnormality in the cervix and we treated it, then your next screening is a year later. But if you come for cervical cancer screening and everything is fine, no problems, then the next screening is
after 3 years.
After 3 years. So generally, that's how we are dealing with the screening. Yeah.
Thank you for that explanation. So how is cervical cancer staged?
Yeah, I think we've talked about it a little bit at the beginning. So usually the staging is really at the hospital. I think for the general public, what we want them to understand is that we don't want them to get a cervical cancer that is advanced. Staging is really a measure of how advanced is the condition. So we have like a stage 1, which is early, then we have a stage 2, and then we have a stage 3, and then we have a stage 4. Stage 4 cervical cancer means that the cancer spread to different parts of the body, spread to the kidney, spread to the bone, spread to the bladder, and so on. So in the hospital, what will normally happen in that case is that we will just do palliative treatment. So meaning that if the patient is having pain, we give them some painkiller. We help with the comfort of the patient. If the patient is having some difficult passing urine, we help them with that. If the patient has anemia, we try to transfuse them. So that's really a late stage, as opposed to stage 1, which is the point at which the cancer has just been detected. It's just on the cervix alone. It hasn't spread to other parts of the body, so it's easier for medical personnel to treat that condition. So really, that's how it's staged. You come to the hospital, the medical officers really do an examination. They look, they are trained to check and see the staging. Really, that's what I can say. You cannot stage cervical cancer from home. You can't just say, no, me I'm stage 1, me I'm stage 4, me I'm stage 3.
One has to go to the hospital.
One has to go to the hospital. They have to examine, they have to do certain tests, sometimes scans and CT scans and other lab examination, checking if how your kidneys are working and so on, and then the final staging is done. So generally, that's what I can say about cervical cancer staging.
So when we talk about screening, is it done at every health facility countrywide, or we've got specific health facilities that do the screening?
Yeah, screening, as we have said, is really the main thing in cervical cancer prevention. It's a method that people in the developed world have used to reduce, to even make cervical cancer non-existent almost, because the cells are caught. These abnormalities in the cervix are found early, and patients are treated before they develop cervical cancer. In our setup, really, there's been very few places where patients have been screened, but those numbers have really gone up. Not so long ago, we had like 27 screening places. I think they moved to 45, and I think right now they are going to the hundreds cervical cancer screening places. But we know that what the Ministry of Health wanted to do is to have at least every district to have a place where patients can be screened. And I think we're very close to that, but we don't have, because every district has different levels of healthcare. They have the health posts, they have the rural health centers, they have the hospitals, and so on. And the hospitals are also classified.
Yes.
The
district
hospitals,
hospital.
the district hospitals, and so on. So we can't say that every facility has this a place where you can be screened. But I think at the moment, people can find a place close to them where they can get the screening, though it's not really as widespread as we want to be. But people in Lusaka, of course, are really privileged. There's several places: Charleston, Kanyama, Chilenje, UTH. You can get to Levi. So Lusaka is really privileged. There's no need for somebody not to have cervical cancer screening in Lusaka. But the rural areas are really underprivileged. But there's lots of expansion now in other districts on the cervical cancer screening. So we're still expanding, but we are not at that level where every facility has a place where somebody can get cervical cancer screening.
For those who are just joining us, today, this evening, we are looking at cervical cancer. That's the topic of discussion this evening. And you can join us on Facebook. Our Facebook pages are KBN TV and Zago. You can be part and parcel of this program by just leaving a comment there, and we can get interacting. Doc, coming back to you, how does the picture look like in terms of statistics on cervical cancer in Zambia? Is it of great concern?
Yeah, cervical cancer is quite common. I think one thing that we've learned again through the COVID epidemics, HIV epidemics, is really for you to just ask someone a question. Do you know someone who died of cervical cancer? Do you know somebody who has cervical cancer? I think most people will say they know somebody who had cervical cancer and died. So it's quite common. If you go to these tertiary institutions, which is where most of these patients end up UTH, Navy, Kitwe Central, Ndola Central, they have somebody with cervical cancer. In addition, I think there's some information in some statistics in 2018 that showed that Zambia had some of the highest number of cervical cancer cases in the world. I think the third highest number of new cases being found with cervical cancer. So it was, I think, 70 per 100,000 women. I think that was like the numbers. So this is it's a very, very common condition. Every hospital you find cervical cancer. So it's not a small problem, and it's really associated with a lot of deaths. I think in the same year, 2018, close to 2,000 women died as a result of complications of cervical cancer. So it's not a small problem. 2,000 women is a lot of women, especially from what we've been saying. These are women that do not need to die. They just needed a cervical cancer screening.
Yes.
Yeah, that's it. At an appropriate time, and those things we've talked about, those abnormalities that are not cancer yet, treated before it gets to cancer. So we see that there are a lot of women dying from cervical cancer. So around 2,000 women, if we use that study from 2018, around 2,000 women every year dying from cervical cancer. That's lots and lots and lots of women, and usually these are women of reproductive age. And women of reproductive age, are like women from 15 years old to 50, 49 years old. These are women that are also in their prime. They're working, they're productive.
Exactly.
Yeah, they can do something. 24, 59, that's really the age range there. So it's quite a big problem, as you can see from the number of deaths, the number of new cases we are discovering, like among the highest in the world, and also from just listening to your neighbor saying that I know somebody who died from cervical cancer. And lastly, you just walking into UTH, I'm sure you find somebody who has cervical cancer. You're walking in Levy, I'm sure you find somebody who has cervical cancer. You're working in these big hospitals, Mansa General Hospital, Kitwe Central Hospital, Ndola, you definitely find somebody struggling with cervical cancer, and so on. So it's quite a big problem.
Could you just explain in details the treatments choices that are there? What kind of treatments are there for cervical cancer?
Yeah, I'll just go back again, just to emphasize that we really don't want a woman to come for treatment for cervical
reach that
cancer.
stage.
No, we don't want. Just get there. It's just we have a view of the cervix. We put acetic acid or vinegar there. You take a picture. You get off the bed. We explain what's going on. If there's an abnormality, we treat there and then. You don't need to go home and come back for treatment later. You get treated there and then. So we don't want to get to that point where we are talking about how do we treat cervical cancer. No, we don't want to be at that point. But having said that, once cervical cancer has been discovered, the ways to treat it involve one surgery, removing the uterus. Because you remember that where the cervical cancer is, it's part of the uterus. So really one option is just removing the uterus. The second option is using radiation. So we use radiation to burn the cancer cells, excuse me, and also some cancer drugs. So that's the second way of treating cervical cancer in our setup. Then sometimes, depending on the stage, we can combine. But ideally, the patients who do very well are the ones that just get one treatment. So you either get surgery.
So that's the earliest stage.
That's the earliest stage, yes. So the earliest stage, usually people get surgery, simple surgery, and the cancer is removed, the uterus is removed together with the cancer. But as the disease gets advanced, the surgery gets more extensive. Yeah. So the more extensive the surgery is, the more the complications. And if the disease advances even more, then we just use radiation and so on, and chemotherapy. Sometimes if you have, that's why I said sometimes some patients get a combination, which is not what we want, but it means that maybe a patient had surgery, and because the cancer was advanced, or the cancer wasn't removed, so then they need radiation and some chemotherapy to get the cancer cleared. So then lastly, there are those patients where the cancer is really advanced, and radiation won't work and surgery won't work. So that's where that palliation comes in, trying to make the patient as comfortable as possible, trying to make them have a comfortable life before the end, because once cancer is spread, then the next thing is death, really. So we are trying.
There's nothing that can be done there.
That can be done. Just trying to make the patient comfortable. If they have no blood, we try and give blood, because if you have no blood, then you have problems. You're breathing badly. You're tired all the time. Sometimes the kidneys are affected. We try and support that and so on. Yeah, so just supporting, but that's now really at a late stage. And I think that's why we are emphasizing that the commonest symptom that is probably cervical cancer is abnormal vaginal bleeding. So we want patients to come early, because the earlier the patient comes, the less complicated the treatment. As we've heard, you can get a simple surgery, or you can end up with surgery and end up with radiation and so on as the stages advance. So we want this cancer, really cervical cancer, found very early, and if possible not at all, because we are all going for screening. Very few people actually getting this screening. I think it's less than 20% of women in our country that are getting to screening. And you can see I'm just going back to screening because having worked in a rural setup, I see that once you get cervical cancer, you're really stuck, because now you have to come to Lusaka. There are no relatives in Lusaka. Most patients just say, it's better I die at home. I don't know anyone in Lusaka. It's like telling somebody to go to Dubai for treatment. The way our patients in the rural areas suffer, you telling them go to Lusaka. Some of them have never even left their village. Now you're telling them to go to Lusaka to get treatment. They just stay in their homes and die there. That's why this screening thing I keep talking about is really the way we should be working, because this screening is taking 5 minutes. You are off the bed, you are going home. 10 minutes, you're off the bed, you are going home. Other than now, you have to go to Lusaka, and there are queues because it's only one hospital that is doing the treatment.
And just on that one, Doc, why do we just have one hospital that's giving treatment to cervical cancer when it's of great concern, as you've already explained earlier?
Yeah, because I think that it's the burden is high. I think the burden is high, so we need more facilities handling these patients. But we have an infrastructure problems. It doesn't cost little money to set up a cancer treatment center. We have a lot of problems. We have COVID, we have malaria, we have TB, we have HIV. So setting up a cancer treatment center is not something that is cheap, for lack of a better way to put it. It's a big investment. So, but I know that the government is trying to get a cervical cancer treatment center in Southern Province, on the Copper Belt, and so on, these places. So we are getting there, but the issue is cost. And then the second thing is just human resource. We have very few specialists. In this case, gynecologists, physicians that deal with cancer. These people have been trained in South Africa and so on, most of the ones we have and so on. So the training, the numbers are not a lot, and we don't have the infrastructure that is needed, which is very expensive to do. But I think that we'll eventually get there with time. Yeah, with more awareness, with more advocacy, with more finances, with time, we can get more places have these facilities. Yeah.
So coming to treatment, how long does treatment last when one is diagnosed with cervical cancer?
Yeah, that's that's a huge question. I don't want to. The patients won't be very happy with me if I give information that is inaccurate. I think that what I need to say is that in our country, because of the only one hospital, there's lots of delays to patients being treated and so on. It doesn't mean that if you show up at the cancer disease hospital today, you get treatment today.
It's not there and then.
It's not there and then. So they do the tests. So you have your cervical cancer. First of all, your medical officer suspects that you have cervical cancer. So they have to do what is called a biopsy. So they get a piece of tissue from the area that looks like it's cancerous, and that tissue goes to the lab. These labs are not all over the country. I know patients from Southern Province and from Western Province sending samples to Lusaka for them to have a diagnosis.
And that takes a bit of time.
That takes a bit of time, a month sometimes 2 months, sometimes 3 months. Sometimes patients have to move to Lusaka to look for their sample. I can't get my results. Where is it? Where are the results? So that's where the problems start. So now this cancer is advancing. Somebody's still waiting for results. Now they get the results. Because when you're coming to the cancer disease hospital, you need a result that have cancer, and this is the evidence from that tissue that you took. So they want that evidence before they can get you. So you can't go to cancer disease hospital and the doctor said I have cervical cancer until you have that biopsy result. So once the patient has a biopsy result, then they reach the cancer disease hospital in Lusaka, and they find the specialists there who talk to them. They open files, then they do tests. They check are the kidneys working well, do you have enough blood, is your liver working well, because you can't get cancer treatment. Cancer treatment, especially for advanced cancers, needs you to be in relatively good health, because the medicine is very strong. So we check that you can handle the radiation, you can handle the chemotherapy and so on before you get to there. So there's so many delays. Patients have come to Lusaka, stayed for a month or 2 waiting for their chance to be treated. So there's really queues for treatment, and there's several sessions as well. So you get your first session if you are getting radiation, you get your second session, and you get your session, and people are following up what is going on. So it might take a long time for the whole treatment. Like we've already said, the ones that end up easier are those, let's say, the stage 1s, that what you need is to cut out the cervix or remove the cervix, because the cancer is just on the cervix alone. It hasn't spread, so they're in the early stages. So with those, it's much easier. Then they just have to go on a theatre list. I'm not sure how heavy theatre lists are for cervical cancer patients at CDH, but that's really an easier prospect, because all you need is that surgery. We book, we put you on the list, then you know exactly when your surgery is, and then you can get that surgery, and then it's done. So the point in the discussion is that we really need to work hard not to get to the later stages, and we really need to to work hard not to get even to the cancer stage, because once we get to that stage, there's maybe one gyne-oncologist, two gyne-oncologists, three maybe in the whole country. So who's going to operate on this patient? They have to queue up because there are other patients that have been diagnosed early. So even if we know what to do, it takes long. So this treatment is there, but it takes a long time because of all these logistics, from the biopsy to the few surgeons to maybe only one machine being used for radiation and so on. So all that is really part of treatment, because that's what is on the ground. So we can't talk about a treatment that is in Europe that you show up and tomorrow everything starts. Our treatment really takes a very
long time
because of all these constraints.
So are there situations where I come for screening, I've been found with cervical cancer, that's stage 1, and I've been treated. I go back, then I go for another screening, I'm told I have it again. Are there any instances where it can reoccur?
Yeah, that's a good question. Yeah, we can't say it's impossible, but I think the commonest reason that we see that somebody comes back, that cancer has reoccurred, is usually that maybe the whole tumor wasn't removed or treatment wasn't effective for some reason. Then the patient comes back, they are back bleeding again and so on. Yeah, because once cancer is advanced, then maybe during surgery, the surgery is difficult, not everything is removed because of the difficulty of the surgery. And then the patient comes back and says, oh, I still am bleeding. So I think that's the commonest scenario, that the treatment wasn't really complete, the whole cancer wasn't removed, and then the patient comes back with similar. So it's possible for those zones usually, yeah.
So one of the preventive measures I've had to avoid cervical cancer is one to avoid sexual activities. But what about for the married couples? How can one say that they should prevent sexual intercourse for them not to get the disease?
Yeah, I think from the discussions that we've had, really, if you are sexually active, you cannot avoid getting human papilloma virus. It's very, it's not really, let's put it like that, it's not possible if you're sexually active for you to avoid the human papilloma virus. Very, very few people who avoid the human papilloma virus when they are sexually active. So really, the intervention here is not preventing people from having sex. I think when we talk about cervical cancer and sex, what we usually talk about is making sure that starting sex too early is avoided. It's a risk factor. You know, adolescents, 16-year-olds, like we said at the beginning, there it must be avoided because it predisposes those young people to cervical cancer in the future. But in the adult world, if I have to put it like that, really the key is screening, like we've put it. Get screened every 3 years. Get screened. Then there's no way you're going to have cervical cancer if you get screened, because we are going to see the eggs, as I've put it at the beginning of our discussion. We're going to see those eggs, those abnormal cells that might become cancer in the future, and we are easily able to treat them. We treat them with heat, we treat them with cold, and the story ends there. So if we intensify on screening, and I have already said that's where the problem is, less than 20% of women are screened. If we just pick 10 random women on the road, how many are screened? You just find that 1 out of 10 or 2 out of 10. That's where really the problem is. So if we focus on that, then we solve the problem. Sex will always be there, of course. That's how we all got here.
Yes.
So yeah, there's no way of preventing that from happening. So the key really to getting cervical cancer eliminated is getting every woman screened, every woman of reproductive age, like we said, everyone who's between 15 and 59 and HIV positive should be screened. Anyone who's HIV negative and is between 25 and 59 should be screened, and they should be screened every 3 years. If an abnormality is found and they are treated, they should be screened after a year. That's what we've said, and that's really the focus of the cancer prevention program. Yeah, that's really the key. Of course, there is vaccination. I'm sure that that question might come later, but since we're talking about really the key interventions, it's not really preventing people from having sex. It's getting everyone screened and getting our kids have some vaccination for cervical cancer. So there is vaccination
At what age
available.
can one get that vaccination?
Yeah, so the idea of cervical cancer vaccines is that we want someone to have the vaccine before they become sexually active. That's really the idea. Again, that stems from the discussion that we've already had, that if somebody's already sexually active, they've already contracted the human papilloma virus. It's very common. You cannot avoid the human papilloma virus as long as you're sexually active. So that person we are trying to give the vaccine, it's too late. They've already contracted the human papilloma virus because
So,
they're already
Doc,
sexually active.
are you saying one who's sexually active cannot get the vaccine?
So the guide, let's get to your actual question, which was the age. So the age is, we are vaccinating children between 9 and 14.
9 and 14.
Yes, because our Zambia Health Demographic Survey clearly states that most of our adolescents start having sex for the first time around 16 years old. So we just drop the years quite a bit to get the ones that are unlikely to have had sexual intercourse. So those are the ones between 9 and 14. Those are the ones that we are giving
The vaccine.
The vaccine. So generally, that's the idea behind the between 9 and 14. And generally, we've been just giving girls this vaccine. So that's the age at which we are treating, and that's the reason generally.
So someone who's just 15 cannot access this vaccine?
I think they probably can. There'll be, I think there'll be some exceptions here and there, depending on the circumstances, because we don't treat numbers, isn't it? We treat human beings when we come to the hospital. So I think some considerations can be made depending on what's available, what's the history of this 15-year-old, and so on and so forth. But our guide, because of what I've said, most adolescents have had sex by the time they're 16, and so on. So the guide is that we vaccinate children between 9 and 14, and yeah, if there are exceptions to be made, they'll be made on an individualized basis. But that's really the guide that is there.
Okay. So I believe Zago's goal is to save lives of women and adolescent girls. So as an association that is concerned with the problem of cervical cancer, how do you reach out and motivate eligible women to go for screening?
Yeah, I think the problem we have with cervical cancer is really knowledge. Yeah, knowledge about what cervical cancer is. It's interesting. I think I saw a study which talked about women being asked, do you know what cervical cancer is? I think very few women said they knew what cervical cancer is, which is quite sad.
Very sad, yes.
Looking at how common the condition is, how many women are dying from this condition, how many women we have in our facilities with cervical cancer, you'll find that most women might not even know what cervical cancer is. So I think our role as Zago is really raising awareness, which is what we are doing right now, trying to get people to know what cervical cancer is, how you can easily avoid cervical cancer by just getting screened. From 2013, there's been vaccination for young girls, as we have already said, and sometimes just because of all these anxieties and fears we have, our traditions and so on, we are saying, oh, my child might not have a baby if they get vaccinated. The same fears that people have had with the COVID vaccinations and so on. They've been there with the cervical cancer vaccine, but that's that's what I think the main issues are with Zago. One, making sure that we spread the knowledge, we make women aware of what's available, and then that's the knowledge bit. And then the second bit is really us speaking for women. I think you highlighted the fact that why do we have only one hospital? Yeah, I think it's the role of Zago to advocate, to speak for women and say, why do we really have only one hospital with so many cervical cancer patients with so much waiting time for treatment, so few labs to do what we're calling pathology to make a diagnosis of cervical cancer. Very few, and patients paying sometimes money to get these samples processed fast. So really our role for advocacy for these women, because a woman in Western Province or in Wapula cannot stand and go to the Minister of Health and say what is going on here. So really those are the things that we are working on. One, to speak for women, and two, just spread the knowledge about cervical cancer. Yeah.
Thank you, Doc, for that explanation. As we come to the close of the program, what are your few closing remarks?
Yeah, so thank you for that. My closing remarks are really what we've talked about already. Women of reproductive age, let's get screened. Let's find a clinic and get screened. We don't want this number to be only 20% of women screened, only 60% of women screened. I think the government wants that number to go as high as 65% at least, minimum. So let's get out there and let's get screened. It's a simple procedure. If something wrong is found, somebody is treated there and then. Let's not be afraid, because once we get cervical cancer, then we are really stuck. Yeah, there's no better way to put it. We are really stuck. Especially if we are out there in the rural areas, away from Lusaka, we are really stuck. So let's get screened. Let's the young girls get vaccinated, and so on. All these things have been proven to work out there, and therefore let's get our kids vaccinated. Let's get ourselves screened. It's once you get screened. The next screening is after 3 years, and so on. That's a good period. It's not like we want you to come every month to get screened. So the message is screening, 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 screening is our way out of this problem of cervical cancer.
Screening.
Yes.
Thank you so much, Doc, for having made it to this program. It was a pleasure having you here again. To our dear viewers, we have come to the end of the program. Today we were looking at cervical cancer, and Dr. Aubrey Shanzi just gave us a more deeper explanation of what it is and how it can be prevented. Please remember, we are here every Sunday, and we'll be here next Sunday from 20 to 21 hours. Put those reminders, and also you can follow us on our Facebook pages, which is KBN TV and Zago, as well as our YouTube channels, which is Zago and KBN TV. This was Inside Health with me, Tumenji Chinjili. Till next time, it's bye-bye. It is said there cannot be universal health coverage without enhanced sexual reproductive health and rights. This is why the Zambia Association of Gynecology